One of the challenges medical students face is trying to understand what to learn. Because the way it's presented in class, everything seems equally important. And so you're left trying to learn everything, and it's just not possible. And so you're left with this terrible anxiety because you don't know what's going to be tested. And so you compensate with the ritual behavior of memorizing and memorizing and memorizing. And we know it only lasts a month. And then when I ask you a context question, you've only got facts, so you don't know how to use them. The way around that is to first of all recognize they can't fail everyone. So the national exams are going to test you on the use of your facts and to accept that you can't know everything. So clinical orientation allows you to have images and stories and a script that medicine uses, because we have to use that in patient care. So when I talk about foundational diseases, today we're going to talk about human papillomavirus, you can see all of the elements that you need to be able to understand the disease, and at the end of that process, then reverse it and start from the patient experience all the way back to the pathology. It's really difficult. It makes students very anxious. You've spent a lifetime memorizing. And so if you're really close to your exams, don't do it. It's too difficult, it's too worrisome. But if you start recognizing you're going to learn this way and you start early enough, I promise you, I've done this with thousands of students, it works. Every week, I'm going to do one of these sessions in which I'm going to take some idea of how to go about learning medicine rather than memorizing all of first aid, that I promise you will help you with your exams, decrease your anxiety, and sets you up for absolute success in your clerkship. Be sure to subscribe. Today I want to further explore an idea which I'm developing as I'm teaching my medical students now. And this is the idea. It's the idea of how important is a disease. And so I want to introduce this idea. There are foundational diseases, there are major diseases, and there are minor diseases. Let's talk about what I mean by that. When I say foundational, I mean that it teaches really important principles. And so that's what you've been seeing me doing. You've been seeing me doing diseases which you've got to know, so much that you've really got to, when you do, for example, cystic fibrosis, man, you have to know everything to understand that disease. But in teaching that disease, it broadly takes you way out of the single disease into how do epithelial work, how do organs work, how do principles of pathology work. Boy, that's a good foundational disease. A major disease is either really common or it's really important because it teaches a really important principle. When I say major disease, I expect you to know presentation, pathophysiology, and natural history. And remember, when I say presentation, symptoms, signs, that's your physical exam, and testing. When I say natural history, imagine yourself talking to your patient. I mean, what is the patient going to ask you? So when you say you have breast cancer, she's going to ask you, what happens to me? That's prognosis. What do we have to worry about? Those are complications. And then last, is there anything we can do about it? That's treatment. So when I say diagnosis and treatment in medicine, you notice they're both built on having a really good understanding of pathophysiology, or that's not going to be a major disease. A minor disease matters. You just got to know what are the relevant facts for it. And they might be anywhere from 2 to 6, and you sort of go, well, you should know that about that disease. So what I've been showing you is the idea of foundational diseases. And today what I want to use as a foundational disease is human papillomavirus. Now, this is the first time I've given this lecture, so feel free to say what I could have done better. But the more I've thought about this, and I'm teaching it to my students now, I really like this disease. Because what we haven't talked about is how do you approach infectious diseases? And I know from teaching, it's really frustrating to teach. And I've thought a lot about why it's so frustrating. And I realize it's because we're not doing it the right way. So this is how I want to introduce the idea of infectious disease. Just as an aside, when I say infectious disease, you should be saying bacteria, virus, fungus, parasite. We talk a lot about the language of medicine. And when you understand how a language process works in any given setting, you have the ability to predict what's going to be said next. So, for example, if I say World Cup, you're pretty sure something related to soccer should follow. So when I say infectious disease, Pretty sure what's going to follow is it bacteria, virus, fungus, or parasite? That really settles you for how the script of the medicine is going to go. Fine, okay. But when we're doing infectious disease, this is how I want you to learn it. I want you to have these 3 circles in a Venn diagram. Over here, we're going to start with microbiology. And that's a whole thing, right? You got to say, what's the natural reservoir? What are its virulence factors? What tissue does it attack? How does the body respond? And so on, right? There's a lot to learn there. Can't learn it for everything. But the next thing we want to talk about is the pathology. So once that organism damages the tissue and the host has an immune response, well, there's pathology there. Don't put that with your microbiology. It's different. You should break it out. It's really different. And then look what the third circle is going to be, clinical. It's all well and good to take H. pylori, and it's all well and good to create a peptic ulcer, but the clinician is going to start with epigastric pain. So don't think that because you got the micro and the path down, that tells you what to do with the clinical. And of course, with the clinical, you've got to not only diagnose it, you've got to decide how to treat it. So clinical is a big whack for antibiotics, isn't it? And then that whole world of resistance. When you start thinking this as a medical student and not a subject-based learner, do it on the 3. Okay, let's take a look at what HPV does. HPV is such a great organism. So let's talk about, first of all, how do I think about viruses, right? So I'm not very good at this, so you can appreciate it's going to be pretty basic. When I say virus, how do I think about the viruses? I mean, it might be embarrassing to say, but this is how I do it. I do it into DNA and RNA. And then, I'm always good on end special cases so I always put my reverse transcriptase RNA here as HIV. I don't give it its whole category. It's just so important. It's going to be one of my foundational diseases. So I just kind of put it there. The other thing, because it comes up in all the exams, is you ask whether it is naked or it's got an envelope. Man, if it's naked, that's a pretty rugged virus. It doesn't need any protection. Pretty sure that's going to be my GI viruses. If they can get through the stomach acid without any protection, that's a pretty tough virus. But my envelope, this is a much less robust organism. So I'm going to think about this much more as my respiratory, my blood, my sort of weenie viruses. So that's a pretty good way of doing it too. But if you want to take all of this and do it by organ, well, of course, you know that, right? I mean, if you've got headache fever and I say it's infectious, yeah, well, you've got to do the viruses that do the brain. So that's all clinical, and that makes perfectly good sense, and we learn them with each organ system. So when I say HPV, we start out, just like I said, with the microbiology, and it's a double-stranded DNA. Well, I break those out specially, right? The first thing that's different is RNA replicates in the cytoplasm, DNA in the nucleus. So let's do a nice little HPV virus, and let's talk about how it's going to infect, because it is epidermotropic. Oh dear. So one of the first rules you say when I say viruses, remember viruses are tiny particles that have cell membrane structures, let's call them ligands, that bind to very specific membrane structures on the cell, which will be called a receptor, right? So this means they are tissue, got it? They go to a specific type of cell, tropic, meaning to bend towards. So just like heliotropic is to go to the sun, viruses are tissue tropic. So when I say HPV and it's epidermotropic, you're going to think of this as squamous epithelium. And now we understand why this is going to be a foundational disease, because I guess you got to know something about squamous epithelium, and none of you do. I know this. I teach you guys every day. None of you have a clue. So we've got to do that because that's the environment that the virus grows in. So let's just take a look. Let's do a squamous mucosa. Really easy to see in your mind's eye, isn't it? And we're going to break this into 4 stages. You all know this. This is going to be my basic 1 cuboidal cell layer. So that's going to be layer 1, which is going to be my basalis. Note to self, basalis is the only layer that can divide. So all mitoses are basal layer. If they start getting above it, pathologists are going to say that's dysplasia. So note to self. The next thing it's got to be is it's got to develop what a squamous epithelium is, which is really strong. It resists shearing. So I can take my hands and I can do this with them and I don't tear the epithelium off. Well, you got to design for that, right? So the way it's going to be designed is I'm going to take my cell, and they're just a bunch of soap bubbles. Well, that's not very strong, is it? So what I've got to do is I'm going to rivet them together. These cells have many, many desmosomes. Okay, well, great. Now I've riveted a bunch of soap bubbles. The next thing I'm going to do is I'm actually going to cable them. And I'm going to cable them with my high molecular weight keratins. So when I say squamous and you say to yourself strength, you're going to add in your mind's eye desmosomes and keratin for cabling. The way we always test you on this is we say, what does it look like under the microscope? Well, when we prepare tissue for microscopy, we dehydrate it, so the cells all shrink. So if you take a look at the cell here in its normal state, has all of these desmosomes. When we shrink it, the rivets are still in place, right? So it looks like this. And so those we can see under the microscope, those are our prickles. You can say to yourself, prickles are a hallmark of squamous epithelium. So the next layer we're going to develop, number 2, is those are going to be the spinosum layer. That's where we're going to have the desmosomes, and we're going to start creating the keratin. Okay, that's good. So now I've got strong cells. The next thing I've got to do is I've got to create a barrier effect out of this. So this is going to be my granulosum. Now you can imagine we can get into all kinds of details, not today, but yes, you should know how to do this. What we're going to do with this is the first thing we're going to do is we're going to take all of that keratin bundling, the tonofilaments, and we're going to glue them with filaggrin. Yeah, that's the filaggrin of atopic dermatitis. So yep, this comes up in all sorts of pathology, foundational disease, right? So we're going to glue those. So now we've made bricks out of everything, and we're going to have keratohyalin granules that are going to put all of this lipid waxy glue out there, and then we're going to glue it. So in the granulosa layer, we're literally going to be making a brick and mortar structure, which is going to be really impermeable. And then the last thing we're going to do is we're going to dissolve all the cells and just compress them into a single matte layer. And that's going to give us our corneum. So when you talk about squamous and you say keratinaceous epithelium, in your mind, you're going to be talking about cornification. So again, this is a foundational disease, right? I can't talk about the virus until you can do squamous epithelium. Okay, well, great. Now we've set it up. Let's talk about our virus. So here's how the virus has to work. Here's my HPV. It's a nice little circular thing with double-stranded DNA. Got it. It's got to attach to a basal cell. Because remember, the cell has to be proliferating. So you're welcome to infect a keratinocyte. Its division machinery has been shut down and will do you no good. The virus can't co-opt that to proliferate. So it's got to infect a basal cell. Everything you've been taught about viruses, when I say they're tissue tropic, we always say to ourselves, here's the virus, what is its ligand on the surface, and here's the cell, what is the receptor function that it's going to bind to in the cell. That's how we've always taught it, right? Lots of famous ones in here, and of course, we all love testing one because that's really basic microbiology, but let's just do some of them, right? Here's, for example, my SARS. So that's our COVID virus, right? That's going to be AT2. Yeah, so we can go down the whole list and you appreciate, wow, this really looks testable. And the answer is, yeah, this really is testable, right? So here's my ACE2 for SARS. How about influenza? A and B. What's it going to bind to? Yeah, perfectly testable. That's going to be my sialic acid. Pretty fun list, right? We can keep going. Let's do a few ones. The ones that we all really love, obviously parvovirus, because parvo B19 is going to bind to the P antigen on erythroblasts. That's why that's the only cell line that disappears. I'll just do a couple more because they're so famous and I know you've learned them, so this is your reward. How about HIV? That's going to be my glycoproteins 120. And then remember, that's going to conformational change for 41. And that's going to bind to, yeah, right, there's my CD4. So that's pretty important. Anything else you want to do? Oh, yeah, EBV. Everyone always asks you EBV. And we can talk about the glycoproteins. They're not as important for this one. But this is going to be our CD21, which is our B cell. So this is a whole list, really fun, and we could just stop off and make that a lecture. It'd be a really fun lecture to talk about how the cells attach, how they go through conformational changes, either go through pinocytosis or they create pores, and in they go. I mean, that's just part of understanding the microbiology of viruses. Yeah, HPV doesn't. Of course, there's always an exception, but to understand HPV as an exception is to think about what's the rule. So HPV binds to the basal cell. It has to. Well, how does it do that? Well, what it does first is it's first going to bind to the basement membrane. So once it binds to the basal membrane, that's going to cause a conformational change in L2, and L2 is going to bind to the extracellular matrix. And once we bind the extracellular matrix, that's going to do a conformational change in L1, and that's actually going to bind to the basal cell. Why does this matter? Well, everything that it's binding to, you can see here. The basement membrane is a universal collagen 4 for all epithelia. The extracellular matrix has the same common glucosaminoglycans anywhere you go. So this seems to be breaking the rule of tissue tropic. But you'll notice, how does this then become only infecting squamous cells? And the answer is, first of all, it can't infect a squamous cell unless it gets access to the basal cell. So you can see in this case, the only way we can get access to the basal cell is if we have some sort of split in the epithelium. You're not going to see that in most epithelia, but we are going to see it in squamous epithelia because it's exposed to mechanical forces. So right off the top, splitting is going to introduce a relatively specific tissue. Second is, even though all these tissues have the same basement membrane and extracellular matrix, in this case, because we've been put in by the split, we can see that our virus here is limited to the number of basal cells that it can infect, because it's got to be access to the basal cell. But the third thing is this: even if it was in the wrong place and it did the wrong basal cell, it's got to go through the keratinocyte machinery. And now all of a sudden, it can infect any cell that it wants, but it's not going to actually be able to proliferate because it specifically needs the squamous epithelium. And you can see that's why we took the trouble to talk about this. Now, it's not worth going into the molecular of the keratinaceous machinery and how it uses it, but understand that's what it's designed for. So when I say HPV is a squamous epithelium, it turns out it's actually not cell specific on ligand to receptor. It's actually specific to access to basal cell, and once in it, co-opting that specific machinery. So now we've done the tissue. Let's talk about what happens when it's in the tissue. So here we are in our basal cell, and remember, it's a DNA cell, so we're in the nucleus. And when it's in the nucleus, it's going to take a ring form. And this is where it becomes a really special organism, because it's got these late antigens it's going to use for the capsid, really immunogenic. It's not going to produce the L's till it's way up here and it's nearly gone to try to restrict the exposure of its antigenicity. What makes it so special is it's got these early proteins, E1 to E7, and after it starts to proliferate, it's got 3 E's you've got to know. The first E you've got to know is E2. This is going to be regulatory. We'll talk about why we need that a lot. And then the 2 you know for sure, if you haven't been waiting for, here they are. There's going to be E6. This is going to be our inhibitor of P53. And then we have E7, and this is going to be our inhibitor of RB. I can't continue talking because now I've got to be able to say, do you understand how these proteins work? That's why this becomes a foundational disease. Why do I care about those 2? We're just not going to memorize them, okay? So here's what you have to be able to do, because it's the molecular pathway. I start off in neoplasia, and you're going to see it all through your phys. When we talk about cellular phys, one of the receptors you've got to be able to do is our receptor tyrosine kinase. So I'm just going to dance through it. This is not like you can say, we could spend a whole week on this, but yes, you've got to be able to do this. Here's my receptor tyrosine kinase. And remember, when I get a ligand, it's going to cause phosphorylation of tyrosine, so I've got a transmembrane signal. This is going to have docking proteins, which is going to activate RAS. This starts a kinase cascade, RAS, RAF, MEK, to mitogen activated protein kinase. This is going to go into the cell and activate a transcription factor. Great. But look what you got to be able to do now. with that transcription factor, you've got to be able to now do the cell cycle. This is the big gap in everyone's experience. So let's do a cell cycle. Yeah, you've known it since grade 6 and never knew why you learned it. So here's my G1, S, G2, hem, right? It makes you feel slightly ill even looking at it. Okay, so what happens here? The whole thing depends right here on the G1S checkpoint. Every time I talk about regulation of a cell, in your brain, what's next? The G1S checkpoint. So what lets a cell go through that? Here we do. We have to build this in. Don't want to hear the whining, man. You just got to know this. This is really foundational. The protein that lets it go through this is E2F. E2F is going to be inhibited by RB, so we can't get a cell through its cell cycle without freeing up E2F, right? So this is, I universally use this to inhibit and this to stimulate or increase. Really works well. Make up your own if you want. That works for me. So RB inhibits E2F. Well, I've got to inhibit RB to go through the cell cycle, and that's my cyclin-dependent kinase 4. Cyclin-dependent kinase 4 comes from cyclin, and in the first stage is cyclin D1, and that's what your tissue factor stimulates. Well, supposing you were a virus that had to keep the cell cycle proliferating, the two key regulatory proteins are going to be starting with RB. So you can imagine when I have my E7 and it goes and inhibits RB, my cell is in perpetual growth. Remember, I've got to have proliferating cells to use the DNA machinery to make me and my proteins. So if you're in the basal cell, how do you prevent it from shutting down in the spinosal layer? Well, how about you inhibit RB? That's really useful. The second thing that you've got to be able to do is remember that this matters DNA health. So anytime you get genomic stress, DNA health is monitored by P53, the guardian of the genome. And if you hang up and don't go through that G1S checkpoint, P53 monitors that. And if you're unhealthy, it activates apoptosis. Okay, well, can you do apoptosis? None of my students can, just so don't feel too bad. So this goes to our BCL2, which inhibits Bax, because Bax is going to go to the mitochondria, and you can see what's going to happen. If P53 doesn't like cell health, it goes up here and it inhibits BCL2. I disinhibit Bax. Here becomes my mitochondrial outer membrane pore. Out comes my cytochrome C. And now I'm down my pathway because I've activated caspase 9 and I've got apoptosis. So if you want to prevent a cell from shutting down because it's infected, say, by a virus, then obviously what you're going to do is you're going to inhibit P53. I mean, it's really elegant. I mean, it's really quite lovely. We're going to use this all over cancer, but viruses and cancers have many of the same gain of function and loss of suppression because these are the key steps you've got to know. So look at the two things that I've already said you've got to do before I can even talk to you. You've got to be able to talk a bit about viruses. You got to be able to talk about a squamous epithelium, and you got to be able to talk about the critical molecular pathways in cell proliferation. Well, okay, so let's come back to our virus. So now we've got, here's my cell, here's my nucleus, here's my virus, right? It is opened up, it's captured the cell machinery, right? And remember, the whole thing is, how do I avoid immunity? Well, that's where we come to E2. We've discussed E6 and E7. You know what E2 does? It actually inhibits E6 and E7. And this is what's so diabolical. By doing that, it means that the HPV will only cycle with the epithelial basal cell, which means there are very, very few viral particles. It's creeping along, infecting cells, but there are very few copies because it's matching its proliferation to the cell's proliferation. So that infection goes a long time before it creates enough antigen to be detectable. It's quite diabolical, isn't it? So here we are back to our epithelium. Here's our virus down here, and it's creeping along, hiding in the basal epithelial cells, and it has low immunogenicity. And then it's going to hit a critical point where it's going to burst out and then get full immunogenicity at the top, and off go the other viral particles. So that means it's really slow to find. Now understand, 90% of these will be cleared over months. So eventually its immunogenicity doesn't do it, but in those months, there's enough time for it to keep spreading. So what happens with our cancer? So I'm in my nucleus, here's my double-stranded. Imagine if I took my virus here at my E2 and I fractured that. Well, now what I've got is I've got a linear virus, and it can insert in my host DNA so that we're going to get this. Well, look what we went through. We broke E2. So when it inserts, pouring off this is going to be E6 and E7. When we translate into the pathology and we say, when does your viral infection go from low grade to high grade? It's when we lose all control of regulation because we've damaged E2, and you can see it in the cells because this is when we get high grade dysplasia. And now it's in your DNA and it's proliferating like mad, and that's when you have a risk about 10% every 10 years will actually get enough mutation to go on and form a squamous cell carcinoma. So let's just talk a bit about where we are. So when I said to you, you've got to be able to do the microbiology. Look how long we've talked, and I've just lightly touched on what you've got to do to understand HPV. Well, what we haven't talked about is what happens with the pathology. Because now we're going to have to do this, right? Here we come along, and this is our usual carcinoma sequence. So I have to go through dysplasia, carcinoma in situ to invasion. Then I've got to have my lymphovascular invasion. That then is going to go to my regional lymph node. And from my lymph node, it's going to spread to my organs. And the common organ it's going to go to is going to be the local draining organs. So I'm going to see lots of involvement of remote things like lung, liver, bone, right? So that then becomes, as we talk about it in the pathology, that now becomes our carcinoma in situ, T, and M. And we can talk about all the information that goes into that. And then we've got to talk about how it tends to be a local metastasis. And of course, the question we're always going to ask you is, what's the problem with the local metastasis? And that's going to be our ureter, and they die of renal failure. Well, then we come to clinical, right? And now we have to talk about all the things that go into screening. We're going to have to go into colposcopy and biopsy once we find the infection. And then we've got to talk about how we stage and treat with surgery preferably. And in the screening now, we have to talk about, are we going to screen for the virus? Because this is mostly 16, 18, but there's another 8 of them, aren't there? Or are we going to do this by the infected cell? So this is going to be our cytology and tissue. Wow, so this is a foundational disease. You've got to be able to talk about the microbiology, how that reflects in the pathology, and then last but not least, how are you going to care for your patient? What are all the tests we do? It varies by age. And at the end of this, after you've done all of that, we talk about prevention, and now we're talking about our vaccines. But all of that is built on this basic understanding of the virus and the molecular basis of that virus infection. Once you've done that and you introduce that virus infection into cells and create the pathology, all of your clinical is going to be built on that, right? It's my old saying, clinical medicine is built on a foundation of basic medical sciences. So clearly, you can't put all this in a book. The whole book would be one disease. You can see even with this little lecture, I really have trouble just trying to give you a quick overview of it. So that's why we're creating a learning community, because we want to be able to say, oh, you can't do that part of this. Let's explore it in depth. Come back next week when we're fresh and we're ready to learn again because we're not saturated. And let's talk about this other side. Let's talk about cytology. I spent my life in cytology. Well, let's talk about the virology. Yeah, we built a genomics lab. We're really proud of that. So as you are learning as a student, come and master a bit of this, and then come and talk about it so you can build on it and become a master of this foundational disease. We did a brief overview of HPV, and you can see I spent most of my time in molecular and cells because I think that's what people have the most trouble understanding. But you can see that when I said infectious disease and you need the 3 circles of the Venn, you probably never heard that before, had you? Knowing how to organize the subject that you're learning and learning to always know where you are solves what, in my experience, is the biggest problem for medical students. They never know quite where they are, so they don't know which fact they're supposed to bring forward. And so in this discussion, you can see I set up how you have to approach infectious disease, micropathology, and then the clinician. We're building out a community of medical learners. It's going to basically be for medical students. Everyone's welcome, and that includes medical educators. And in this, we're going to be doing all sorts of growth objects centered on the fact that I'm going to be live and you can come and speak the language of medicine. Medicine has a script. Do you have it in your head? What must follow when I use these words? And you can bring your problems, you can bring the questions you can't do. You can certainly embarrass me, I don't know everything, but you'll get a chance to come and learn how clinical medicine is built on a foundation of basic medical sciences. And I hope you can rediscover some of the joy in medicine. It's pretty obvious I have. For more information, you can click the link in the description. In the meantime, if you want to see how well you're doing, I put out a modest number of multiple choice questions that are quite clinical and based on foundational ideas of understanding. Go give them a try, see how you do. It's a free series. The link is also in the description. See you next time.